Hello, my name's Stephen Ashmore and I'm one of the directors of the Clinical Audit Support Centre. The purpose of this short enhanced podcast is to provide you with more information around a piece of work that Clinical Audit Support Centre have been doing in terms of looking at how to take clinical audit to the next level. This podcast focuses really on the presentation that we were asked to give at Healthcare Conference's National Clinical Audit Conference, which was held in Birmingham on the 5th of October. The work has been undertaken by both myself and my fellow director at CASC, Tracy Ruthven. This podcast falls into two distinct halves. First of all, we're going to be looking at what we called the good, the bad and the ugly of clinical audit, which is very subjective but personal viewpoint from Clinical Audit Support Centre on how we think clinical audit is currently going in 2016. And then we're going to focus on 7 key recommendations that we feel could help move clinical audit to the next level. I'm sure you would have your own viewpoints in terms of what's currently working in clinical audit, but for us, this slide outlines what we feel are really the good things about clinical audit in 2016. Clearly, clinical audit is making a difference, and there are many projects out there that are improving patient care, both local and national. Some of the national audits, particularly the stroke audit, is seen as not just a UK-based leading project, but it has international recognition. Compared certainly to 2006, we now have many more resources to support clinical audit, whether that be the support from the Healthcare Quality Improvement Partnership or other internet services that have taken root over the last 10 years. Local audit teams certainly are invaluable in driving clinical audit forward, both at a local and national audit level. We have regional networks, so for example in Leicestershire, we are now attached to our East Midlands group, which has been in existence for 20 years and is highly established, giving local audit professionals the chance to get together and share ideas. The CQC have certainly focused minds when it comes to clinical audit, and you only have to look at what's happened in primary care, where the quality and outcomes framework had really taken over the clinical audit agenda. CQC are now reporting that clinical audit needs to be undertaken in much more detail in GP practices, and that's definitely moving clinical audit forward at that level. And we also see lots of examples and case studies, for example our junior doctors competition, some of the HQIP award winners, real examples of where clinical audit has made a difference. So having looked at what we consider to be the good, let's move to what we consider to be the bad. And I'm not going to go through all of the bullet points on this slide, but let's focus down on a few of them. First of all, we feel as though there is a real lack of leadership when it comes to clinical audit, and this has been proven by some of the recent work that the Clinical Audit Support Centre have undertaken. We appreciate that local audit staff have a lot to do, but if you look at knowledge in relation to who at NHS England level, at HQIP level, in relation to some of the national groups, who the key people are, there's clearly quite a disconnect between those undertaking clinical audit and those at a high level. And leaders should be a bit more visible for us at a national level. There's certainly an issue in relation to national clinical audits, and this is an ongoing feature of any discussion when we evaluate clinical audit. Our view hasn't changed over the last 10 years. National audits for us are still too big, they're too expensive, and they often don't focus on clinical audit standards at all. And those of you involved in these projects will often see that they're more quasi-research as opposed to true clinical audit. We would say there are too many clinical audits. If you speak to staff working on wards, delivering care to patients, they'll often tell you that they are bombarded with clinical audit projects, often that in their view don't make a significant difference to patient care. And I think that's something that the clinical audit community has to address in 2016. We need to focus on completing more clinical audits. We've moved very much away from what we would call interface audits as well. They're projects where we look at the care across care pathways. So it might be looking at the care of a patient who's been seen in hospital, but is then followed up by their GP, or community services, we often, still in 2016, focus our clinical audit work on uni-site delivery of care, and that's something which could be very much improved. When it comes to focusing on what we would consider to be the ugly side of clinical audit in 2016, again, I'm not going to go through all the bullet points on this slide, but it gives you an appreciation of how Clinical Audit Support Centre view the current situation. We'll come on in our recommendations to talk about national clinical audits and how we think they could be taken forward, but there's certainly a lack of diversity when it comes to national projects, and pretty much all national audits focus on acute hospital-based care. There's examples of local audit projects that don't improve patient care, that needs to be addressed. I think it's fair to say there is a persistent image problem in relation to clinical audit. You only need to look at Twitter to see how sometimes clinical audit is viewed by those taking part in it. And I think we've seen in recent years an emergence of quality improvement projects and methodology, which although is useful, sometimes can give a negative viewpoint in relation to clinical audit. We've seen a decline in investment, certainly at a local audit level, that is somewhat surprising and unfortunate, given the plans to reinvigorate national audit, and certainly the commissioners that we meet don't often have an appreciation of how they could be using clinical audit effectively with the organisations and providers that they work with. So that's our quick recap in relation to what Clinical Audit Support Centre believe is the current good, bad and ugly of clinical audit. Let's be a bit more positive and focus on some recommendations that we feel in 2016 could really help drive clinical audit forward and take it to a new level. So first of all, we've got to remember that 10 years ago, as I've already mentioned, there was this big national initiative to reinvigorate both local and national clinical audit, and that appears to have disappeared, unfortunately. As part of that project in 2008, a consultancy company called Frontline were commissioned to do a survey reviewing the state of clinical audit effectively across England, and that was quite a considerable piece of work. Clinical Audit Support Centre would say that it's now time for that piece of work to be recommissioned. After all, we work in clinical audit, we're people who like to measure how we're doing, and that's what we expect of those healthcare professionals that we work with on a day-to-day basis. So surely it's time, given the investment that's been placed in relation to clinical audit, the considerable public funds that have been pushed towards clinical audit over the last few years, surely it's now time to reconduct the Frontline survey to see if reinvigoration has been attained at a local and national level. Not just that, by conducting or reconducting the Frontline survey, we get an appreciation of where clinical audit is from their independent viewpoint in 2016. And you can see from the slide on the screen that their report in 2008 highlighted some key areas of strengths and weaknesses that we've been able to use to help move forward since that piece of work was undertaken. Recommissioning the Frontline survey would be relatively inexpensive, and as I've said, it would give us the perfect opportunity to judge where clinical audit truly sits in 2016 from the viewpoint of an independent organisation. Let's move on to our second suggestion for how we can take clinical audit to the next level. This next slide outlines some of the concerns that we have in relation to the current arrangements for clinical audit. So we do question whether there is a true clinical audit community. We've already mentioned, do people working in clinical audit know who the key leaders are and have access to them? How do people working in clinical audit get their key messages and find out about national initiatives? How do people share resources? After all, there must be lots of clinical audit staff working on the same projects in their own little silos where they would benefit from working with others in the field to take projects forward. This would save a lot of time, resources, effort and money. Where do people get examples of best practice? Again, a lot of clinical audit professionals probably don't see examples of wider clinical audit projects that have made a difference, that have been undertaken in different organisations and different trusts. And we don't probably debate enough the methodologies that we use to conduct best practice in clinical audit. What I'd like to show you in the next slide is a website called Practice Index, and this has taken root within the primary care community, and this is effectively a resource for GP practice managers. Over 80% of GP practices are signed up to this, and this is the way that pretty much all practice managers can find out about current initiatives. There's a very useful forums board where practice managers can share local concerns. They can post anonymously if they don't want other people to know who they actually are. And this is a truly fantastic resource that enables practice managers to find out what's happening, to share ideas, to communicate and network with others. And it seems to us as though this would be a fairly straightforward undertaking to set up something as useful and similar that clinical audit professionals could access. Of all our 7 recommendations, perhaps what we consider to be the most important is our view that it's very much time to diversify the National Clinical Audit Programme, as was recommended by Sir Liam Donaldson some 10 years ago. Now, those of you that work in the acute hospital sector will know just how many national clinical audits you and your organisation are expected to participate in. But I'm not sure if you're aware of the situation in relation to other healthcare providers when it comes to national clinical audit. For example, if we look at care homes, there is currently no national care home audit, yet there are 21,000 care homes in the UK, currently looking after over 300,000 residents, often patients at the end of their life who are particularly vulnerable. And if we look at the CQC reports, we'll often find that actually care homes are amongst the most poorly performing healthcare providers in terms of the ratings that they attain from the CQC. And it's not just care homes that are untouched by the National Clinical Audit Programme. For example, if we look at prisons, the current prison population in England is over 85,000 inmates. Again, like care homes, made up of individuals who are probably very vulnerable and potentially going to be within the same environment for quite a long period of time. So again, we think it would be useful to undertake a national clinical audit focusing on patient care within the prison service. If we look at primary care is almost untouched by the National Clinical Audit Programme, and for example there is no national audit for dentists despite the fact that there are over 15 million dental appointments per year. Of course, we can continue to conduct our national audit programme focusing on the acute hospital sector, but is that really a viable and useful approach in 2016 when there are so many patients in other healthcare environments receiving services from different healthcare providers who are not touched by the National Clinical Audit Programme? And we would highly recommend that NHS England look to diverting even small amounts of financial resources to the likes of care homes and prisons and primary care services to evaluate how patient care is delivered in these settings. Our 4th recommendation also focuses on national clinical audits, and we feel that in 2016 it's time to conduct a user survey of all those involved in undertaking national clinical audit projects. We are unaware of any such project that's been undertaken, but a centralised approach to gaining feedback on national clinical audits would be invaluable to gain an appreciation of the strengths and weaknesses of these publicly funded pieces of work. Moving away from the national agenda for a moment, we really feel as though it's time to reinvest at a central level in the reinvigoration of local clinical audit Certainly from a Clinical Audit Support Centre perspective, when it comes to talking about reinvigoration, that's a word that appears to have almost disappeared, particularly at a local setting, and we would call on NHS England to really look again at how they are trying to reinvigorate local clinical audit. From speaking to local audit professionals involved in both national and local projects, many tell us that local clinical audit is what does lead to fundamental improvements in patient care within their organisation. And we do worry slightly that the national audit agenda is overrunning local projects, and we need to consider this. When HQIP were established, they focused a lot of their resources and time on reinvigorating local clinical audit, and many of you will be familiar with the excellent guides, resources and documents and best practice pieces of work that they put together. HQIP also ran a national conference. They also had an annual awards showcase which collected case studies in clinical audit that could be shared across the profession. And they also had a quality improvement team made up of 3 or 4 staff who were always willing to come out to local events and help drive clinical audit forward at a local level. Unfortunately, in recent times, we've seen pretty much all of those resources disappear, and it's a shame that that is the case, and we would very much again encourage HQIP and NHS England to consider how they can better support local audit professionals undertaking the work at the coalface in 2016. It's our view that if the local clinical audit community isn't supported, then that will have a very negative impact on all clinical audit work, but particularly the delivery of the national audit programme and not just local projects. Our penultimate recommendation might surprise many of you, bearing in mind we're a clinical audit organisation, but put quite simply, we believe there is too much clinical audit being undertaken in 2016. You only need to speak to the hard-pressed doctor, nurse, community health professional, dentist, GP, etc. and they will tell you literally just how much work they are undertaking and the variety of priorities that they are having to consider. There are many clinical audits they're being asked to take part in that they consider to be of limited value, that are not improving patient care, and it is a big concern when clinical audit starts to become what is merely a tick box exercise. So we would say that we need to really consider what clinical audits we ask professionals to take part in, and we need to make sure that clinical audits that are done will improve patient care, will attain the re-audit status, and will help drive care forward. Perhaps aptly, our final recommendation focuses on patients and patient engagement. Those of you that have worked in clinical audit for over 10 years might remember the work of Marcia Kelson back in the 1990s, when she suggested that it was imperative to get patients engaged in clinical audit projects. And that meant trying to get patients involved in choosing clinical audit projects, involved in helping decide actions from clinical audit projects, helping patients understand the clinical audit process, giving them access to results, and getting patients just more engaged with the work we do as clinical audit professionals. The graphic that you can see on the screen is the results from the Clinical Audit Support Centre annual survey from 2012 to 2015, and these underline just how little patient engagement is currently taking place when it comes to clinical audit. It is hugely concerning that in 2016, most respondents to this survey over the last 4 years have rated patient engagement within their organisation in clinical audit as poor. HQIP have a central team that help those interested get patients more involved in clinical audit, and we would encourage you to contact their lead, Kim Rozelle, as she has many ideas that can help you in terms of making patients more aware of clinical audit and getting them more involved in the process. So this is something, again, as our last recommendation, that we feel could be driven forward. So that pretty much concludes this enhanced podcast. We hope you found it useful and at least a little bit thought-provoking. Obviously, we're sure that you won't entirely agree with all our considerations and our suggestions in relation to the good, the bad and the ugly of clinical audit in 2016, but we'd love to hear your feedback on the viewpoints that we've put forward, and also we'd really be appreciative if you'd tell us what you think of the recommendations that we've suggested. Thank you.